let's start off. So it sounds like most of you, this is going to be a little bit of an intro. So CMR obviously is cardiovascular magnetic resonance. So it's obviously one of the imaging modalities that we utilize in cardiology. And the mainstay of what we do is really assessment of chamber size, contractile function, because it has very important clinical implications in a variety of different heart disease states. Now, obviously, echocardiography is our first-line modality. The advantages are low cost, portability, and widespread availability. I mean, we'll never be able to do an MRI scan, CMR scan at the bedside in the ICU. That's obviously a strength of echocardiography, but there are some limitations as well. And the biggest, obviously, is suboptimal image quality, operator dependence, and then finally the need for geometric assumptions. So, in the ideal world, I think the advantages of CMR are that it gives you very high quality images with both high spatial and temporal resolution, with excellent signal to noise, free choice of imaging planes, and no need for geometric assumptions. So if you look at the image on the right-hand side, this is a typical CMR scan that we would acquire for assessment of LV function. And this is just one individual short axis slice here, but you'll notice not only can you see the endocardium very clearly, you can also even see the papillary muscles and all these fine trabeculations very, very clearly. And so I think that's one of the strengths of CMR is the beautiful images that we're able to make, folks. So what I'm going to try to do here in the next 15 minutes or so is talk a little bit about how cine CMR is performed, also touch on limitations and strategies that we can employ to try to overcome these limitations, talk about how we actually generate volumes and ejection fraction, and then I think similar to what Roberto touched on earlier is go over the fact that there may be differences between age and gender, and then lastly see how they compare volumes by CMR versus volumes by echocardiography. So this will be what a kind of a complete CMR study for LV function assessment looks like. So you'll notice we start off with these initial localizer images. So this is a 2-chamber view and a 4-chamber view. And then when we go to position or short axis, we actually position off of these 2 views to make sure that we're truly perpendicular to the axis of the ventricle. And then what we do is just simply go through and do individual short axis slices from the base of the heart all the way down to the very apex of the heart, and then we get these stack of images that we show here. And these are typically done every 8 to 10 millimeters apart. So you've got really kind of contiguous coverage of the entire left ventricle from the base down to the apex. And then in addition to that, we do the standard 2, 4, and 3-chamber views, just like we do in echocardiography. And one of the nice things here is that there's no need for IV contrast. And this full series here can typically be done in the order of about 10 to 15 minutes with the use of EKG gating. Now, how do we actually go through and generate these images? So one of the things to be aware of is that MRI is inherently a slower technique than echocardiography or cardiac CT. And so as a result, we have to employ a strategy called segmentation, where we actually obtain parts of the image over several different cardiac cycles and then summate all of this together. So in the example here that I'm showing you to generate this cine loop here, which actually is just a series of images obtained at slightly different points in the cardiac cycle, we would actually go through the first cardiac cycle, acquire some of our data, then go to the second cardiac cycle, acquire some additional data, third cardiac cycle, more data, and then fourth cardiac cycle, complete our image. So it's similar to 3D echo, for example, before the advent of real time, where you would stitch multiple different data sets together, taking over several different heartbeats. Now, the one fundamental difference, though, is that the way that the image reconstruction is done is not by stitching together different portions of the image, but rather it's a concept, which I don't want to bore people with, the concept of K-space, which is the kind of the MRI lingo. But it's essentially the idea that you can generate MRI images with any number of lines of data. So I could actually, just from the information I got from my first heartbeat, I could actually generate an entire image, which is shown here, but it would be a low resolution image. And if I incorporate additional data from the second heartbeat, I generate now a slightly higher resolution image. And if I keep doing that over and over again for 4 to 6 cardiac cycles, that's when then I get finally the high resolution image that I showed you earlier. And so this is just showing that concept again, which is if you reconstruct the images based on the data from just one single heartbeat, it looks like the image you see on the left-hand side. And if you do it over 4 to 6 heartbeats, you get now the image that looks on the right-hand side. And so as a result, though, we're not obtaining separate parts of the imaging field of view. Rather, every line of data somehow contributes to the image. So as a result, the first thing you're going to ask me is, well, what happens if things are not the same between the first cardiac cycle and the second and the third and the fourth? So if a person's having problems with arrhythmias, or they're having problems with the inability to breath hold. Well, that's an important thing for us to be able to recognize, because you obviously want to come up with ways to try to come around those problems. And so the first step, I think, is really being able to look at the image and based on the image itself, recognize, obviously, this is 2 scenarios, 2 different patients. There's a problem, right? The images don't look as crisp as I showed you in the very beginning. So what's the problem? Obviously, to be able to solve the problem, you need to figure out what the problem is. So if you look at the left-hand side image, how many of you think this is a problem of gating versus how many of you think this is a problem of breathing? So raise your hand if you think this is a problem of gating. Image patient A, raise your hand. Okay, how many think this is a problem of not being able to hold their breath? Raise your hand. Okay, so you guys are excellent. I think you guys all figured it out, which is the patient A is a patient who's not able to hold their breath. And the reason for that, you can notice, is not only is the image of the heart blurry, but look at these abdominal organs. They also look blurry as well. Whereas on the patient on the right-hand side, this is a problem of arrhythmia, where you notice the abdominal organs, the chest wall, everything looks very clearly demarcated, but it's really only the heart that looks blurry. And also, if you look at the very end diastolic frame, it looks better than the frames during systole. And again, that's where arrhythmias corrupt primarily your image acquisition during systole. So the question then is, once we've identified the problem, how do we fix it? So one strategy that we can employ is using this thing called arrhythmia rejection. So basically, the scanner will track the RR intervals, and it will say if the RR interval for one beat falls outside of a certain range, so if it's too fast or too slow, then discard that data. And if I do that, this same example here of a person who's having arrhythmias, with using the arrhythmia rejection strategy, notice now I get a very nice crisp image. All right, so this is something that typically should be performed to give you, to eliminate the problems of arrhythmias. Now, you're going to come back to me and say, okay, that's fine, but what if the guy's having a lot of arrhythmias, the R interval's all over the place, or what if they can't hold their breath at all? Then what do we do? Are we out of luck? Well, no. The answer is, again, this is that high-res image I showed you on the left-hand side. This is a 5-second breath hold. You get in-plane resolution of about 1.5 to 2 millimeters and a frame rate of about 30 frames a second. But we can do a lower resolution acquisition, which is done in real time. And that's the image shown here on the right-hand side. This requires no breath holding, but the in-plane resolution is about 3 to 3.5 millimeters, and the frame rate is about 20 frames a second. So a little bit of a compromise. But again, I think if I showed you this image to start off with and said, hey, this is a nice image, most of you would agree and say, yeah, it's not bad. So obviously, we get spoiled by being able to acquire images like this. But what I always tell my techs and my fellows is we should never have an image that looks worse than this. So this is the worst quality image you'll ever get on a CMR scan. And I think it's still not that bad of a quality image. Now, so once we've generated the images, how do we actually compute volumes and ejection fractions? So this is where I think the strength is, because remember I showed you we actually acquire a series of short axis views, so we can simply have then our technologist or our fellow or even the attending can go through and just trace the endocardial contour for every single slice. So you do that in diastole and you do that in systole, you summate those volumes together, and then you generate an end diastolic volume or an end systolic volume. So you'll notice here, no geometric assumptions are required. This is using the true Simpson's rule of disk, not the modified Simpson's rule of disk. And obviously there's a fair bit of validation data that goes back over the last probably 20 years or so, comparing it both in vivo as well as in the in vitro and ex vivo settings, showing, in fact, fairly high accuracy, reproducibility, and low intra and inter-observer variability for CMR measures of both volumes, end diastolic and systolic, as well as volumes of, or measures of ejection fraction. So, a few caveats I think that are important to keep in mind, and again, these are some of the lessons I think we learned from echocardiography, is that typically in echo, when you take a 3D echo acquisition into a post-processing workstation, you're typically making sure that you account for the basal plane. And so in CMR, because it's a tomographic technique, there actually is a anatomic coordinate system here, and the post-processing tools now are actually able to match up the short axis slices to where they sit in relation to long axis views. And that's what those dashed arrows are showing you here, that these individual short axis slices actually sit at different locations in the left ventricle. And I can actually visualize that, and I want to make sure that when I'm doing my tracing, that I'm tracing up to the very base of the heart. So you don't want to lose any volume, but then also keep in mind the fact that there is a reduction or there's a movement of the basal plane that occurs between diastole and systole. And if I show you this example here, in diastole, you can see this line right here, this basal slice, corresponds to the end of the heart, to the base of the heart. But look what happens during systole. There's a significant base to apex descent. And so as a result, if I were to trace this image for generating volumes and ejection fraction, I'd want to make sure that, in this case, I trace the basal slice in diastole, but look at that same exact slice on the right-hand side in systole now actually sits within the left atrium, and so you won't want to exclude that slice from your left atrial volume tracing. Now, again, because the image quality, I think, is so good, you've got very high signal-to-noise, the actual post-processing, although we always laugh and say, okay, we make the text do this. The reality is, let me show you how simple it can be now, is I've actually got here, basically, I place a seed point and then just do a seed grow algorithm, and I just pull that all the way until it gets to the contours of the myocardium. So it literally took me a couple seconds. So I could go through and trace this entire slice within probably, or this entire series within probably a minute or so. So it's no longer time consuming. It's no longer something where you generate the images and then you come back a couple hours later to actually get the values. This can all be done in a very rapid fashion. Now also we've got numerous studies that have shown normal volumes, and a few things I think to keep in mind is that normal volumes are dependent on age, and this actually is a nice study which looked at patients in different deciles of age from the 20s, 30s, 40s, all the way up to their 80s. And you'll notice if I point out the end diastolic volume by BSA, or the end diastolic volume index, and you look at the upper bounds of that, for a 20-year-old, it can be as high as 101 milliliters per meter square, but for a 70 to 80-year-old, it can be as low as 88 milliliters per meter square. So again, the normal values get smaller with aging, and this just shows that in a graphical fashion, that the normal values for end diastolic volume gradually get smaller. And the same thing applies also for ejection fraction, which is if you look at the lower bounds of ejection fraction. Now this is also an important distinction, I think, is that typically in echo, people would probably consider lower limits of normal maybe in the low 50s, whereas by CMR, typically it's high 50s is considered the lower limits of normal. So if you get an EF of 53, we would probably call that a mildly depressed LV function. But also keep in mind that normal ejection fraction changes a little bit with age. So older patients tend to have slightly higher ejection fractions, normal, than younger patients do. And then also men and women, there's a difference as well. And I think Roberto touched on this also for echocardiography. We find the same thing by CMR, is that men in general tend to have slightly higher volumes, end diastolic volumes, and in systolic volumes than women do. And then lastly is the fact that the normal values that we have differ a fair bit from echocardiography, where the normal volumes are probably anywhere from 20% lower. Now, what's the reason for that? And I think Roberto very nicely published a study a few years ago trying to investigate the reasons for these discrepancies between CMR and echocardiography. And I'm not going to bore you with it, or I'm not going to go into too much of the details since he already touched on this. But I think the findings that he demonstrated in his study were also demonstrated in numerous other studies. This actually is a meta-analysis of 65 different studies with close to 3,000 patients, again showing that by 2D echo, there's a significant negative bias. In other words, LV volumes by echo, by 2D echo, are much smaller than they are by reference CMR in the same patients. 2D echo with contrast reduces that bias, 3D echo has a slightly lower bias, but still on the order of about 14 mLs. And then obviously multi-detector CT values by CMR, or between CMR and CT correlate fairly closely together. Interestingly, although end-diastolic and end-systolic volumes tend to be underestimated by echo-based techniques, ejection fractions tend to be pretty comparable across all modalities as far as no negative bias. And obviously, as far as the source of the underestimation, I think it has to do again with these trabeculations. I think Roberto showed this already, so I'll skip past this. And in that particular publication, they actually did a very nice job of saying, okay, if I basically undertrace the CMR, so if I ignore these trabeculations, then you actually get a much tighter correlation with echocardiography, potentially explaining the reason why there's a discrepancy in values. Now, let me move on to the right ventricle, and obviously in the interest of time, I'm going to skip through the, or I'm going to go through this fairly quickly. But CMR is really able to give you very good delineation of right ventricular endocardium as well. And some may say, is it really that important? How important is complete visualization? Well, looks like you're out running on a nice sunny day, but if you see the whole story, maybe you're not so happy, right? So again, I think complete visualization is essential to anything we do in cardiology. And one of the things to keep in mind is that, with CMR, for the RV assessment also, we're going to do it off of a series or a stack of short axis views. And I think that's different than if you just look at long axis views. And the reason for that, this is very nicely shown, is that I can actually do a 4-chamber view that cuts the right ventricle through 3 different planes. And based on the specific plane that I've got, the size of my right ventricle on just a linear dimension can be very different. And so I think, again, this is why you want to really do your RV volumetric assessments off of the entire ventricle, not just without having to make geometric assumptions. The ideal technique would also be fairly reproducible and would also have established normal reference values. Here's examples again. This time we'll focus on the RV, and you can see upper on the top is a patient with normal RV function. The patient on the left here, and again, you can see the endocardium fairly clearly of the right ventricle. You've got a patient with severe RV dysfunction, and on the right-hand side, you've got a patient with severe RV dilatation. And so how do we go through and actually compute RV volumes and ejection fraction? Well, it's actually the same methodology that we did for the LV, which is the stack of short axis views. We then go through and trace the endocardial contour for each individual short axis slice. Again, make sure that we account for the proper base to apex descent, and then summate these volumes together, again, using true Simpson's rule of disk, and generate an RV end-diastolic volume. If you do this in systole, you get an RV end-systolic volume, and then obviously the difference there divided by the end-diastolic volume would be the ejection fraction. And then obviously with all these fine trabeculations in the right ventricle, although we still have fairly good accuracy and reproducibility, there is a slightly higher variability. And in fact, the interstudy variability for the right ventricle is probably on the order of about 5 to 6% versus about 2 to 3% for the left ventricle. So there is a little bit more variability as would be expected. But again, where CMR could be useful is in patients where you want to serially assess for anything that causes changes in the right ventricle, as well as to assess, for example, the impact of valvular lesions, PI and TR, on right ventricular volumes and right ventricular ejection fraction. And again, just as with the LV, there are differences between men and women, and I'll skip over this in the interest of time, but you need to always reference it to normal values for specific gender, as well as specific age, because notice, if you look, for example, for men, the upper limits of normal for a 20 to 29-year-old man for RV end-diastolic volume index can be as high as 114 mLs, versus for an 80-year-old, maybe 98 mLs. And so what you don't want to do is start calling people as having RV dilatation or RV dysfunction simply because it's a young person. And because the EF also tends to be a little bit lower in younger patients than it is in older patients. And then lastly, left atrial volumes can also be done by CMR. And again, obviously, we're using the same basic principle, which is to assess the maximum left atrial volume that occurs typically during ventricular systole. And there's 2 methodologies that can be employed. One is the biplane method, similar to what's used in echocardiography, where you do it off of a 4-chamber and a 2-chamber view. and there's validation studies using that methodology. And then on the right-hand side, we can actually do it by doing a stack of short axis views through the left atrium and then actually planimetering or contouring each individual left atrial slice and using basically the true Simpson's rule of disc. And there's normal values by both methodologies. Important thing to keep in mind is that for left atrium, the normal CMR values, index values, are between 26 and 53, which compares to the upper limits of normal by 2D echo of 34. So again, you don't want to look at a CMR report and says 48 mLs per meter square and say, oh, this must be severely enlarged LA. That's actually normal. So you need to always make sure that you compare or you reference it to whatever the normal reference range is for that modality. So to summarize, I think many would say CMR may be the reference standard for volumes and ejection fraction because of optimal image quality, limited need for geometric assumptions. We have established normal volumes and ejection fraction. Important to keep in mind that these normal values vary with age as well as with gender, and that CMR normal values differ from echo. And so you want to make sure you're comparing apples to apples, not apples to oranges. Thank you for your attention.